So if you want to take it away there, Ciara, and I will flick on the slides for you.
Okay, thank you. Thank you, Katie. Hello, everybody. I'd like to welcome you all this morning. I'm going to do a talk about pressure sores. I would like to acknowledge Spina Bifida Hydrocephalus Ireland and Katie for giving me this opportunity to talk. And I would also like to acknowledge the parents who have given me consent to use some pictures of previous pressure sores that I've came across in my time working in Temple Street. So I'm just going to move now to the next slide. Sorry, Katie. So the purpose of the presentation is to provide information on pressure ulcers, how they develop, and the steps that can be taken to help reduce them. It's also to provide information regarding what to do if a pressure ulcer develops, and also to highlight the shared partnership in care with you, the parent, our carer, your child, your local multidisciplinary team, your public health nurse, your orthotist, and the Spina Bifida team in Temple Street. And by working all together, I believe it results in better outcomes for your child. I'll just move to the next slide if you don't mind. I'll move to the next, thanks. So I said I'd start off with basically explaining skin. So skin is a vital organ that covers the entire outside of the body. It forms a protective barrier against bacteria, fungus, and injuries from the environment. Skin allows for sensation of touch, heat, and cold, and has up to seven layers of epidermal tissue, and it protects the muscles, bones, ligaments, and internal organs underneath. The three main layers, you don't need to know all the layers, the three main layers are epidermis, which is the outermost layer of the skin, and it provides a waterproof barrier and creates our skin tone. The second layer is the dermis, beneath the epidermis, and it contains a tough connective tissue with hair follicles and sweat glands. And then underneath is a deeper subcutaneous tissue, which is made up of fat and connective tissue. I'll just move on to the next slide. Thanks. I just got a picture of the skin. So as you can see, the first layer is epidermis, the middle layer is the dermis, and the underneath is the cutaneous tissue. I'll move to the next slide. So what is a pressure ulcer? It's injury to the skin and muscle and tissue underneath. Blood flow to the skin and tissue is reduced. Oxygen and nutrients that the skin and tissue require to survive is reduced. And tissue becomes starved and begins to die. And then a pressure ulcer begins to form. So any areas of redness or break in the skin caused by too much pressure results in a pressure ulcer. I'll move to the next slide. Let's move to the next slide, Katie. Thanks. So why are children with spina bifida at increased risk of pressure sores? Due to reduced sensation. So they may have limited feeling or awareness of pressure and pain and temperature. We know the nerves that are affected as a result of spina bifida affects the motor function as well as loss of sensation in certain parts of the body located below the defect, such as the legs or the feet. Nerves, as I said, limited feeling of awareness of pressure or pain and temperature. Nerves at the site of injury are impaired, which results in impaired messages sent to your child's brain. So I suppose if they don't have the sensation that they can feel that there's pressure on their foot, they won't be able to move away from it. Reduced muscle ability to move off or away from pressure, and decreased circulation when muscles are less active, which results in reduced oxygen and nutrients the tissue and skin needs. So I suppose if the muscles aren't moving, they're less active. Thanks, Katie. What increases the chances of a child with spina bifida developing a pressure sore? If they're a wheelchair user, if they are, say, in the summertime, if you have them out in their bare feet, they may be on ground and they may not have the sensation that their feet are being dragged over stones. They may not have that. Obesity. So obesity is linked to numerous health problems, including skin infection. For patients with spina bifida who may have obesity, maybe further impair their mobility and add on to an increased amount of pressure on the skin and contribute to skin breakdown. If they're underweight, I suppose if they're underweight, their bones may be more prominent under the skin, depending on the level of lesion, bladder incontinence, shunt in place, above knee orthopedic surgeries, or if they had a recent surgery which occurred which means that they may be immobile for a little while, and spinal alignment if the child has kyphosis or scoliosis. I'll move on to the next slide if that's okay. Thank you, Katie. So last year, I met 24 children, and I kind of looked at, from what I've seen, from the level of lesion, did they have a shunt, their ambulation, and the location of pressure ulcer? Did they have a high BMI or a low BMI? And if they had recent orthopedic surgery? So the children in the group of their MRI level of thoracic T1 to T12, 8 out of 24, they all had a shunt and they all were wheelchair users. 5 of them had developed pressure ulcers on their back, 2 on their feet, and 1 on their hip. 1 had high BMI, but the other 3 had low BMI, and 1 had recent orthopedic surgery. Then at the level of lesion of lumbar L1 and L2, 5 out of 24 all have a shunt and all are wheelchair users. 4 developed pressure ulcer to their bum and 1 to their feet, and none of them had elevated or low BMI, and none of them had recent orthopedic surgery. Lumbar level L3, 2 out of 24, and all have a shunt and all are wheelchair users, and 2 developed pressure ulcers to their feet. None of them had low or elevated BMI, and none of them had orthopedic surgery. Lumbar level L4, 1 out of 24, all have shunt, and all had a wheelchair user, and he developed it on his bottom, and he had low BMI. Lumbar level L5, 4 out of 24, 3 out of 4 have shunt, and 2 out of 4 are wheelchair users. 2 developed pressure ulcers to their feet, and 2 to their bum. 1 had high BMI, and 1 had recent orthopedic surgery. Sacral, 4 out of 24, and 1 out of 4 had a shunt, and 1 walked with HFOs, and 3 had AFOs. 2 developed it on their bum, and 2 on their feet, and 1 had low BMI, and 2 had recent orthopedic surgery. I'll just move on to the next slide, Katie, if you don't mind. How to reduce the risk of pressure ulcers developing? I suppose the first thing is to look at your child's skin every morning and night when dressing and undressing for any areas of redness or discoloration. Change position. Your child should change their position every 2 hours throughout the day and every 4 hours during the night. Change regularly. If your child is incontinent, you change their pads regularly. Apply a barrier cream. Take note of changing frequency, and if increased, maybe contact the Spina Bifida urology nurses who may need to review their bladder management. Equipment. Trial new equipment as directed by your local OT and orthotist. Example, orthotics, wheelchair, standard. Complete skin check with each session and check for areas of redness. If areas of redness are noted, contact your local OT, physio, and orthotist. And the HSE in 2018, they recommend regular wheelchair assessment and pressure relief or redistribution should be offered to children who are long-term wheelchair users. Clinicians should regularly reassess and measure splints, orthotics, garments, and other medical devices to ensure they fit correctly as children grow and develop. Next slide. How to reduce the risk of pressure ulcer development, your child's skin condition. If your child's skin is dry, apply moisturizer. However, be careful not to apply too much moisture, as this can lead to skin breakdown. Avoid hot water when bathing, as this can result in dry skin. Dry your child's skin by patting as opposed to rubbing. Applying creams. Do not massage the skin to prevent pressure ulcers. If the skin is fragile or swelling is present, this can further damage the blood vessels. Diet. Encourage your child to eat a well-balanced, healthy diet with plenty of fresh fruit and veg and protein-rich foods, and to keep hydrated. Transfers. Avoid anything that causes friction to the child's skin. Example, do not drag your child up the bed, and if at all possible, try and avoid bum shuffling. Next slide. So what causes pressure sore? Pressure from the weight of the body, equipment, example AFOs, wheelchair. Friction or shear, if the skin is pulled or continuous rubbing off surfaces. Moisture, increased likelihood of skin breakdown, And if your child had a previous pressure sore or pressure ulcer, their skin will be more susceptible to further breakdown. Next slide. Pressure. So skin breakdown pressure sores can develop in parts of the body that are constantly pressed or squeezed. Ensure your child's shoes fit correctly and are not rubbing against their skin. Ensure your child relieves pressure on his or her bottom by leaning side to side or pushing the bottom off the chair every 15 minutes. A general rule is to watch where the bones are right under the skin and there is constant pressure, like the back, bottom, ankle, and toes. Next slide. Thank you. Your child can develop skin problems anytime his or her skin gets wet and stays wet. Areas around the upper thighs and the bottom are the most common places for skin problems to develop moisture. For school-age children, wetness may occur between catheterization. Next slide. Anytime your child's skin comes in contact with a rough surface, your child could get cut, scraped, or burned. To protect your child's skin, make sure your child is wearing shoes when he or she walks or goes swimming. Protect the skin from rough surfaces. Wear high socks under Afos to cover the skin where the Afos touch the skin. Wear appropriate clothing when using the stander or wheelchair to avoid rubbing from equipment, and try and avoid bum shuffling if possible. Next slide. Heat. Hot surfaces and direct sources of heat can burn your child's skin. Since your child has limited feeling in his or her legs, they may not be able to feel their skin hot and tell you they're hurt. Watch out for other sources of heat, such as electric blankets, heating pads, hot water, hot sand at the beach, direct sun and sunburn, car seats, outdoor swings and playgrounds, radiators, indoor and outdoor fires, candles and holiday decorations, and hot surfaces in the kitchen. Next slide. Where do children with spina bifida get pressure ulcers? Most frequent places are on their feet or ankle, bottom or back if they have kyphosis and scoliosis. Next slide. So this is a picture of a child who has kyphosis and developed a pressure sore. You can see that there is redness around the skin and it is broken down in the middle. Next slide. This is a child who developed a sacral pressure ulcer. It was quite extensive. It was. The child actually had to go to surgery and had to have plastics involved and did need to have a back dressing. But the main cause of it was that the child was continuously bum shuffling. But you can actually see from the wound that it did heal. It did, and this tissue here is granulation tissue. This is all new tissue that's being created, and it did heal. Next slide. How do I know if my child has a pressure ulcer? Red marks on fair-skinned children, purple or blue marks on dark-skinned children. Discolored skin does not turn white when pressed. Skin feels hot to touch and may be shiny. Broken skin, blisters, pain, or there's a foul smell. Next slide. There's different grades of pressure ulcers. So grade 1 appears as a defined area of skin discoloration. It's usually red, blue, purple, or black, and it's non-blanching. And non-blanching means when you press on the skin for 5 seconds, you hold for 5 seconds, and then you remove, and if the color doesn't go away. That's what non-blanching means. Next slide. Grade 2 is some skin loss or damage involving the topmost skin layer. The ulcer is superficial and presents as a cut or blister. You can see this child has the cut on her foot. Next slide. Grade 3 is full thickness skin loss involving damage to or necrosis of subcutaneous tissue that may extend down to and not through to the underlying skin. Next slide. Grade 4 is extensive destruction, tissue necrosis, or damage to muscle, bone, or supporting structures with or without full thickness. And this child did develop a sore on her hip. Initially, they thought it was caused from a belt. It was. She was seen by the OT in Temple Street, and she was seen by plastics as well at the time. This child as well had scoliosis. So she was then seen by orthopedics. So they felt that, and it was her mom actually who identified, felt that when she was positioned backwards, that the wound would heal, but when she would go over again, it would come back again. Child did have the scoliosis surgery, but when she went for scoliosis surgery, the wound did heal before it. Next slide. The impact of pressure sore on the child and family. So there's loss of function and mobility temporarily to the child. So I suppose if they have it on their bum or on their back, that means that they have to stay off it. So it does affect them. Risk of systemic infection, so risk of cellulitis, which is inflammation around the tissue, and risk of infection going into the bone as well once they have a cut. Social isolation, so I suppose if they have a pressure ulcer on their bum and they have to stay off their bum, it can impact on them going to school, missing out on their friends, and more healthcare visits. So it's more healthcare visits to public health nurse, early intervention team, orthotist, Temple Street, and as well as that, it's quite stressful for parents as well. Next slide. Teamwork. Next slide. So multidisciplinary team approach. Early identification of at-risk patients is vital for the prevention and exacerbation of pressure sore development. It's a collaborative shared approach with your child, your family, the local team, and the Territory Spina Bifida team in Temple Street. And wound healing requires a multidisciplinary and holistic approach. Next slide. So what to do when a pressure ulcer develops? The first thing is to alleviate the pressure. Find out what has caused the pressure ulcer, discontinue use of equipment which caused the pressure ulcer, and take the pressure off the affected site. For example, if the pressure is on the child's bottom, avoid sitting as much as possible and encourage side lying or lying in the tummy. And medical devices are associated with 50% of pressure ulcers in children. Contact your local physiotherapist, occupational therapist, or orthotist to review equipment and transfers and to complete a risk assessment. Contact your public health nurse to review pressure ulcer, and contact the Spina Bifida team in Temple Street. Next slide. So Spina Bifida pressure ulcer pathway. The first is prevention, management, and treatment plan, and I'm going to go through each of these now. Next slide. Prevention, local team, parents, child education. So it's important that we educate and teach parents and children regarding pressure ulcers. Risk assessment. All children should have a risk assessment of pressure ulcer by an appropriate clinician using clinical knowledge and observations and using an appropriate tool. A guided assessment of skin sensation. Assessment of posture and positioning will assist with identifying pressure ulcer risk, and this is done by your local OT. Continuous assessment should be repeated and documented as your child develops and grows, or if there is any change in health status or mobility, if a pressure sore develops, or if there is a period of immobility. Work with you, the parent, and your child to discover the level of comfort and function in position over 24 hours and with current pressure management practices. Consider any previous history of pressure ulcers and increase likelihood of future pressure ulcers if the area broke down previously. Skin assessment, skin changes, so the skin colour, oedema means swelling, changes in tissue consistency, skin moisture, Skin integrity, are you looking for any cracks or openings? Skin thickness, signs of itching, lesions, raised or flat bruises. And skin temperature, compare some body parts for skin temperature. You're trying to feel, is it more hotter compared to somewhere else? Care plan. Develop an individualized care plan, outcome of risk assessment and skin assessment. Need for additional pressure relief as identified areas of risk. Consider all equipment the child uses to participate in daily activities throughout their entire day. Review transfer methods currently in use and ability to reposition independent or with support. Collaborative care plan with multidisciplinary team, family and child. Next slide. Wound management. In most cases, your local public health nurse or tissue viability nurse will address wound management. The public health nurse will assess your child's wound and she'll grade your child's pressure. Wound healing in children generally follow the same process as adults, and granulation tissue is created at a faster rate than in adults, results in fasting healing process. However, just remember, the wound will heal once the pressure is relieved. If you have concerns, do not hesitate to contact Spina Bifida team anytime. Next slide. Nutrition. The nutritional needs of children with pressure ulcers that are chronic may be high, and they may need additional protein, calories, vitamins, and minerals to help their wounds heal. A deficiency in vital nutrients may delay wound healing, and nutritional assessment should be performed by a pediatric dietitian or other healthcare professional with the necessary skills and competencies. And that's, I think, me finished now. Thanks very much for listening.
I couldn't unmute myself there. Sorry, I was trying to say thank you very much for that. That was really, really interesting, and quite comprehensive time as well. Thank you very much. I'm just going to open it up now for the question and answer section. Okay. So something has come in there. So thank you so much. It was really interesting and easy to understand. So thank you very much for that. Anybody have any specific questions or anything you'd like to put to Ciara? Will a dietitian referral happen? Question automatically. I beg your pardon. Sorry. Will a dietitian happen automatically?
Well, it will be reviewed on an individual basis, and if it is so, say if a child has a grade 3 or grade 4 pressure ulcer, then they should be seen by a dietitian. Yeah.
Okay. Their questions are coming in fast and furious now, but just one.
Sorry, I can't hear you.
Somebody asked, is it possible to stop a child bum shuffling?
It's very hard. It is to stop a child from bum shuffling. It is, but unfortunately, what we've seen in the last two years, we've seen a few children who have been bum shuffling, and unfortunately, then it results in pressure ulcers. I know. So there was one child who did have a bum shuffling done, and in the end needed corrective surgery on her feet to be able to stand. So again, it is all an individual assessment. It is on it. But when they do have the pressure ulcer caused from bum shuffling, the child unfortunately needs to be kept off the bum.
Okay. And somebody asked here, can you please explain in relation to not massaging skin? So why you don't massage the skin?
So if your skin is, say, it's kind of, so if the skin is fragile, so if the skin is weak and thin, if you go and massage it, you're more risk of further breakdown or breaking down the skin.
Okay. Could be done at home, managing pressure sores.
Sorry?
What treatment can be done at home for managing pressure sores?
So Is that if the child has a pressure sore, or is it to prevent?
Oh, that didn't come in. I would say if they have a sore. That's me guessing.
A pressure. So it is very important. So say if you do identify that your child has a pressure sore, it is very important that you contact your physio or your local OT to review, to first identify what caused the pressure sore, and also your public health nurse as well, because a grade 1 pressure sore could progress very quickly to a grade 3.
In a bit of swelling and a small bruise, but no wound, how long should it take to heal?
A bit of swelling and a bruise. I'd have to
A
see.
bit of swelling and a small bruise, yeah.
I'd have to see it to tell you the truth.
Okay. A comment came in there that thank you for the talk. It was really informative. Another question came in. Have you noted a higher incidence in occurrence with continence management?
Higher incidence in occurrence. To tell you the truth, there was only one child who I seen who was in relation to continence. But there was only one child.
Okay. And what are the best or recommended barrier creams on the market currently?
The creams that we use, well, I suppose every child is different and every parent has their own preference in what works and what doesn't work. I know what we use in Temple Street is now at the moment is Cavalon barrier cream. But sometimes Sudocrem just works, just as well. So it's a personal choice.
Okay. Another one came in. Like I said, they came in fast and furious there for
Sorry.
my son has a pressure sore on his toe from an AFO. They were slightly too small. He's getting new AFO. When can he hear them? Must the skin be 100% better?
Well, in my opinion, I would say yes, that you want the skin to be fully healed before you go and you put back on the AFOs, because if you put the AFOs back on when it's not fully healed, then and especially if they're new AFOs too, there'd be risk of further skin breakdown. But I would say discuss it with your orthotist. That would be my opinion, would be to wait till the skin is fully healed.
Okay, thank you very much. And if AFOs are causing the pressure sore, do we continue to use them? And how do we help prevent further ones while waiting on new AFOs?
Well, I suppose if the AFOs are causing the pressure sores, it is important that you take the AFOs off. And then I know if you're waiting for the new AFOs coming back, it is important that your orthotist knows that that this has caused the pressure sore. And then I suppose work with your local physio and orthotist and maybe even trial it on for a short period. Again, keeping an eye on the skin again. And if you notice further skin redness or that, then unfortunately they have to be left off.
Okay. And that was it for some of the questions. And then there was a few more thank yous that have come in there as well. So yeah, interesting.
Yeah. And at the end of the day,
you get as much.
What did you say?
I just say sometimes from the question and answer section you get just as much information as you would from the presentation. Yeah. So brilliant, Kieran. Thank you.
Yeah. And everybody knows where I am, so you can always contact me anytime you can.
Brilliant, and thank you very
much. No problem, and thanks very much, Katie, and Spina Bifida Hydrocephalus Ireland again, and again for the parents who gave me permission to use the pictures for the presentation, and the children. I really appreciate it, because I think the real pictures are more important than getting pictures from books and articles.
Absolutely agree with you there. Okay, thank you very much, everybody. And just a reminder that the next webinar that we'll be hosting will be functioning, and that will be in 2 weeks' time. And the information will be going up on our Facebook page as well shortly. Okay, thank you very much. And thank you again, Ciara. And thanks everybody for attending and the great questions. So I will say bye-bye to everybody. So thank you.
Thank you. Take care. Bye-bye.